Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Well, it is February 22nd, the last Tuesday of the month, which means this is Talk 10 Tuesday. Some good things have happened in the month of February for me. We have hit our 300,000 listener download. We're actually at 300,000 and I think 127 or something to that effect. But the listens, the viewership, we've increased 33% over the last couple of months. And so really thank you for that. I can't even tell you how much that humbles me, how appreciative I am for the continued listenership that we enjoy on the Codecast podcast and all the real positive feedback that we get from doing what we love to do. So I really love and enjoy this platform and being able to talk to you about things that come up in healthcare, about coding and billing and reimbursement and compliance. And today's no different. I've noticed that a lot of my emails lately have been still about the confusion on the 2021, now 2022 E&M guidelines. Everybody wants to talk split and shared visits. I've done a couple recently. I'm going to move off from that for a little bit, mainly because I'm a little bit frustrated. But today I'm going to start a series of the next Top 10 Tuesdays. So I do these every last Tuesday of every month, as you know. So you're going to get 10 questions related and answers related to the 2021 E&M rules for the office visits and other outpatient visits, because there's still a lot of confusion. And again, it is my number one webinar right now. So I wanted to continue to give you questions and answers that come right from the source, so the Medicare rules and guidelines. And many of the MAC payers actually put out an FAQ sheet on that. And so some information I'm going to get from that, some I'm going to get from the different information that I have that I've put together. But we're going to focus on things like, time visits and medical decision-making and risk and data points. And hopefully this will really add to your workflow. And you'll remember some of these things, be able to, if you're listening at work, just have a sticky note next to you so you can just write a couple things down. I know some of the things that I've been listening to lately, it's nice to get some buzzwords and just some information you're thinking, that makes a lot of sense. One of the things I did recently for a company called NAMAS, so that is the National Association for Medical Auditing. We had 400 people on this webinar call, and one of the things that I'd just like to reiterate, if the OIG is looking into it, then you should be looking into it too. And that is such a true statement. It's not something that we can be lax about anymore. If it's the federal government is going to open up things that they want to get their money back, then it's something that you're going to want to be mindful of. And when I see how easily, and I say this with love, but it does happen, when I see how easily the documentation can be manipulated in the audits I do, not just for my clients, but for payers and for new clients, but how easily the documentation can be manipulated when using time, I would think that that's going to be on the radar for the payers and especially Medicare. It already is for telehealth. And so if you're billing a lot of level 4s or 5s, but then your record itself really from a medical decision-making standpoint only supports a lower or a moderate level, it's going to be challenged. So at some point, you're going to have to be able to support why you needed 65 minutes when the patient truly came in for something that on medical decision-making portion could have only been maybe 30 minutes. Why did you need to take that long when it was more of a low or moderate problem? And so that's what we're going to talk about, really understand the rules and the guidelines, because I'm getting a lot of, it's technically correct. Well, just because it's technically correct doesn't mean it's best practices. So we want to always keep you in that best practice mode so that you're never under scrutiny. And if you are, you're like, you know what, here's my records, take a look, because I have nothing to hide, nothing to be concerned about, and we're an open book. So hopefully we'll be able to do that. But the last Tuesday of each month for the next couple of months, because I've gathered about 45 Q&As, so I like to do 10 to keep it within your drive period or within something that you want to listen to without you're thinking, okay, enough already. And so we'll continue to do that over the next couple of months at the end Tuesday of the month. But first, the Codecast podcast is also brought to you today by Nature's Bounty Vitamins and Supplements. Vitamin D3 supports strong immune health and is CDC recommended for good bone health, and it may help with muscle strength, protection against cancer, type 2 diabetes, and yes, the COVID-19 virus. So again, make sure you're looking into your D3 vitamin supplement. Okay, let's continue to talk about these top 10 for E&M services. And it's interesting because on a lot of these services, you get these Q&As from different MACs, and not everybody is on the same page with what some of the definitions are. And so we just want to see if we can start with time. So let's start there and just try to get a little bit more clarification. So here's one that comes from CGS and Noridian Medicare. It's one of their Q&As. And it's just really helpful because they really kind of clarify what some of the questions have been. Not to the point where it's, clear as day, but let's just say it kind of lightens the load to the murky waters. Okay, so the question one, and you may have heard a lot of this, but hopefully I'm going to give you a little bit of a deeper interpretation so that you can understand what you're looking at, because I'm seeing a lot of still cut and paste generic statements within records that I'm auditing. And remember, the biggest thing that came about with the 2021 guidelines, and I guess we should call them 2022 now, but the biggest thing that came about with the office and other outpatient visits is that Medicare wants you to be individual to the patient, not to be generically putting in templated information for any patient that you see. So that's where it gets a little bit interesting, because even today, for example, I still have physicians saying I spent greater than 40 minutes. I do not give you credit past 40 minutes if you say that. When you just put in generic statements like, if the patient has an episode, we've said to go to the ER. Well, that's like saying, we bubble wrap you in case you get hit by a bus. We don't want to hear ifs or possibilities or anything like that. When we're looking at this, again, from an auditing perspective, where you're trying to support the record, what the payer, and I'll just talk about Medicare, what they're looking for is a physician or provider that has been focused on that patient. That's the patient over paperwork situation, where they want you focused on that patient, not generically using drop-down screens and cut and paste method in your EMR to pad that information so that you can add up the time. So please don't do that, and be specific on your time. So question one, must the patient medical records show specific times and activities for each encounter? So the answer is yes, but let's clarify. It says there's no specific requirements for having a stopwatch, but the best practice, and this comes right from CMS, is to show the activities and the time you spent doing those activities. Recording the start and stop times of your activities is the most complete document, but not absolutely necessary. The medical record must support the level of service chosen. An encounter includes both face-to-face and non-face-to-face time between you and the patient. Now, AMA also documented some descriptions of activities of non-face-to-face. Remember, that has to be done by the provider who's billing the service. It's not ancillary staff. So if you hand off something to one of your medical assistants and said, please schedule this for the patient, that time count stops right then. So it also says CMS includes these instructions, quote, our reviewers will use the medical record to objectively determine the medical necessity of the visit and accuracy of the documentation of the time spent. So they're looking to see if the time actually was warranted. And so when I read that, and that's a quote coming right out of the integrity manual, it means just because you're using time and it could be technically the right amount, it means they're going to say, was this really medically necessary for the use and accuracy of the time? So include everything you can in that. I know that was kind of a long answer to a short question, but we have to be very clear when we're using time that that's probably the biggest thing that's under scrutiny right now. Okay, so question number 2. I spent time reviewing charts and results prior to or answering questions after the date of the face-to-face encounter. Can I count this time in choosing my level of service? The answer is no. When using time to choose your level of service, use only the time you spent on that date of service. So you have to be very clear when you have physicians that say, I'm going to add an addendum or a correction or a late entry or something after the fact. They cannot count that toward their time. Number 3, must I provide counseling or coordination of care to use time to choose my level of service? The answer is no. The AMA does not require you to provide counseling or coordination of care to choose your procedure based on the time you spent, but this can be included in the time you spent. It is not a requirement, but it is part of the activities that could be counted as part of the time you spent. Question 4, if I do not document on the date of the encounter, does this mean I cannot use time to choose my level of service? So here's a controversial answer. It says you can still use the time spent face-to-face for the appropriate non-face-to-face activities on the date of the encounter to choose your procedure code. If documenting the service on a different calendar date, do not include the time spent documenting, but also put an entry for justifying why your documentation was not completed on the date of the face-to-face encounter. I can't wait to see some of those documents. Number 5, the electronic medical record requires records, a start and stop time for the face-to-face visit. How would I document the time spent on the non-face-to-face care? So this is where the doctor has to be able to free type, because the answer to number 5 says, notate this time in the medical record. Medicare would be unable to count non-face-to-face time without some kind of notation in the medical record. Now, some of these answers, just so you know, I'll stop there for a second, are going to sound a little bit condescending. They're not coming from me. This is coming right from a Medicare list. So just know, and I'm expanding on that list based on certain payer guidelines. So just be aware that this is what they're looking at, and this is how they're responding to these questions that came up from the final rule. Question 6, I spent approximately 25 minutes on each patient. Another physician spends 35 total minutes on each patient. How would we choose the correct code choice based on these differences? Well, if choosing your level of service based on time, you code to the time documented. This could result in different levels of service, and Medicare would evaluate the time you documented. So that's twice now that there's been an entry that says that Medicare is going to evaluate your time. I also think this is a good example that brings up a way that I can show you how things can be manipulated. So let's say you were the provider that spent 25 minutes and you're basing it on time. Well, for an established patient visit, that's a level 3, 99213. The provider that spent 35 total minutes on the patient, that's a 99214 in the code range. So here's where there could be a manipulation of services based on just how long each provider spends bedside and what their workflow system is. And it may not be fair, but that's basically how the rules are working. And so in my opinion, as much as I like to see time in the record when it's telehealth, medical decision-making for me helps support it beyond a reasonable doubt. I mean, if I'm thinking a med-legal visit, when you get into time now, because twice Medicare said we're going to evaluate the time you documented. Not that you meet the time level, because technically you'd met it, but we're going to evaluate the time you documented, meaning, did that really happen? That's how I'm reading that. Are you acting in good faith? Does that really need that much time? So keep that in mind as you're listening to some of this. Number 7, I see a new patient and spend 12 minutes on that patient on that calendar day. Can I choose a subsequent patient procedure code? No. So this is still a new patient visit. The 99202 would require at least 15 minutes of time. If providing a new patient visit and you do not meet the time, you would have to then default to medical decision making, and then what is going to be your appropriate code. So you can't basically use something different just because you have less time. And you have to have at least that amount of time. Remember, there's a code range now, so you have to meet the minimum to be able to pick that level of service. Number 8, can I count time spent by ancillary staff providing face-to-face or non-face-to-face services? No. Only time spent by you and possibly the qualified healthcare professional you choose the level of service. But now remember that as of 2022, Medicare was clear that you cannot use this as shared visits anymore. So you cannot share a visit in the office setting for office or their outpatient visits, place of service 11 anymore. So not as of January 1st, 2022. So don't do that. Number 9, how do I document to receive reimbursement for the new extended time procedure codes? Believe it or not, I've actually coded a lot of these, which is interesting because prior to the 2021 guidelines, doctors were not meeting the thresholds. So all of a sudden now they're meeting not only the thresholds, but they're going beyond the 15 minutes and they're meeting it for the level 5 visit, past the level 5 visit. I find that a little bit suspect to me. And so what I've been doing, not just in the audits, I count how many level 5s that doctor has for that day of service. And then I look and see how many E&M encounters they have the entire day. And then I look to see how many prolonged service codes they have. And then I do the math. How long were they in the office? How long did they actually have the scheduled office, and then how long did they spend in any non-face-to-face activities in the office? So what does that show, and did the doctor meet that time threshold legally and appropriately and compliantly? So I find that a very small percentage are not meeting it, so I don't feel that physicians are, overreaching for the most part, but there's that occasional physician that does overreach, and we just have to make sure that we're policing them and keeping an eye on them. So the answer to this, how do I use the new extended time? The new procedure code for Medicare is G2212. So the medical record should show you exceeded the time of the 99205 by at least 15 minutes, or the 99215 by at least 15 minutes. So this is only available to code when you use time to choose your procedure code. This is also a contrast between Medicare and AMA published information. So the time for a 99205 is 60 to 74 minutes. Medicare can allow additional time when you've spent at least 89 minutes on that new patient, because you've added an additional 15 minutes beyond the maximum time. The time for the 99215 is 40 to 54, so now you can use the G2212 when the medical record reflects at least 69 minutes. If you have more than one unit of service, you can submit on one line item with multiple units. Just so you know, there is an MUE of 4 right now. They don't think you're spending 2.5 hours with a patient or more than that. And then if you have an additional unit of service when meeting till the next unit of service, then you have to really look at your, they have a grid in the CPT book, and it's 104 or 84, and really know your time thresholds. Now, a question comes up all the time, and I'm going to give a side note on this, question 9. Should we be following Medicare or AMA guidelines for commercial patients? If you really want to do best practices, the only thing that makes common sense is to follow Medicare on this. Why would you start with the 1 minute over the minimum time and try to add a prolonged service code just because you can? It doesn't make sense. And from a med legal position, I think you'd be in a lot of trouble. So when Medicare put this into play, they were really not happy with AMA. But on the flip side, when I was listening to the AMA webinar last May of 2021, they were mad at Medicare for not following their insight on this. And I'm just like, say it out loud. You're not understanding what they're saying. There's a range for a reason. And remember, all of our E&M services in 2021 and 2022 were increased by almost 18% across the board. And those increases for the RVUs was based on time. And so it wasn't based on medical decision making, it was based on time. And so we have to make sure we understand that's why they only allow the prolonged service addition now to level 5s, because they want to be cautioned about anybody trying to upcode based on time. Number 10, my level of service is 99205 or 215 based on medical decision making. Can I use the new extended time procedure code G2212 added on based on medical decision making? No, this code is added on only when choosing the levels based on time and you've reached the maximum range for time for the originating or primary code before you add this on. So this is where you have to really be careful of what you're doing. So I'm going to actually give you one more bonus question on this one because it actually goes with what we were talking about. It says, do we have to document, so this is question 11, do we have to document start and stop times for prolonged service? So there's actually instructions in the CMS Internet Only Manual, the IOM 100-04, Chapter 12. Look under Section 30.6.15D. It indicates you must document start and stop times for prolonged services. So CMS isn't giving us a lot of information on that, but it is in the online manual. I don't know if a lot of people realize that. So it's not just total time for prolong, it's also start and stop time. And so I had to actually send that over to a couple of my providers that were saying spend 111 minutes with the patient. Well, technically they did allow for all the time to be able to get that add-on code, but I'm not seeing a start and stop time. So we have to make sure that we are following the rules compliantly and doing things the way it is published and documented. Okay, so that is enough of that for this week. But I am excited to keep this going at the very last Tuesday of every month because I think this can be helpful for everyone. I am going to get into some more coding information. I know I've been really focused on compliance and some of the regulatory things that have come up, but I've had a lot of people ask me if I could talk a little bit about dermatology and some of the different coding specialties. So I am going to do a couple of things on that when it comes to looking at just some of the different coding options for the Codecast. So, I appreciate everyone asking me, could you do this? Could you do that? And I think it'll be really some good things that we bring to you. For those of you that have been really listening a long time, I really appreciate that because it's always good to have some new topics. It is hard to find new topics when you're on episode 200 and something. So it's really nice to be able to have everyone kind of join in. And again, today is episode 227. So a personal tidbit today, we are in the countdown for my daughter's wedding. Tomorrow we meet over a Zoom call with the DJ. I'm not allowed to call it disc jockey. Apparently that ages me. So we're looking at music for that. If you don't think I'm not getting some 70s and 80s music in there, you're crazy. But she said it's funny because everybody wants that as well. And then some of the obvious new stuff that's out there. I swear, I just hope it's not a rap fest. You just know that's going to make me sit there and go, what the heck is going on? But anyway, we're in the planning mode. We're down to the last month, and I just can't even tell you how much stress it is, but we're looking forward to a really happy occasion. All right, everyone, have a great rest of your week and make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.